preparing to go live, and I'm allowed to drink water during the session, right?
It's okay. Yeah. Shall I
Okay,
start?
start. Yes.
Yeah. Yeah. Hello, everybody. I think this is going to be a very interesting session because after 60, around 60, right? I mean, how many do we have? The classes now?
59.
Yeah, around 59 classes. So we thought we'll have a session where we allow members to ask if there are any doubts and if there are any queries in this past few sessions that we have done. As and when possible, Dr. J and I try to answer it in the groups or if they personally message us, but we still thought we should have an open house where everybody gets a chance to clarify their doubts because of the lack of time. Many a times we will not be able to take the questions which were on the chat box. So without wasting much time, I will just start with the questions. So these are not arranged in an order from basic to advanced. So as in how I have got it, I have just written it down and I will start asking him. So one role of GSF in FET, is there any role? I mean, do you use
GCSF, right?
GSF?
No role.
And what is the cutoff value for LH and estrogen progesterone for FET cycles?
Uh, Prior to starting progesterone, I guess.
Yeah, yeah, yeah.
So LH is something which we don't measure. Estrogen, ideally, if you are on HRT, to be more than 300, 350, and progesterone to be ideally less than 1.2. Okay. But you can have little modifications up and down based on if you're using a modified natural cycle or something like that.
Why don't you measure the LH?
There is no role, no? HRT is already going to suppress, if you have a hormone induced cycle, then LH is going to have no role. Simultaneously, if you are doing a modified natural cycle, then at the day of starting progesterone, there is no role because before that you would have already given a trigger, right?
No, but what if the LH is high, say on the day that you start the progesterone? So you
Hmm.
see a beautiful triple line and you have good
No
blood
problem.
flow and you have your
No
T2
problem.
around 300.
Yeah,
If the LH is like,
if it
say,
is if it is an HRT cycle and LH is 30, I mean that's not going to happen because of estrogen going into HRT. LH would go down, but let's assume somebody has measured and the LH is 10, 12, whatever. It will not affect anything.
really? What
Yeah.
about like, I mean, this is just my thing. So whenever we see that the LH is above, say, 10, okay.
Hmm.
See what usually we do or we try to say is the LH has to be kept below 10 just
Fine.
before
Yeah.
between. Yeah. So for FET cycles, I mean, just take it as like 10. Okay.
Yeah.
So if in that case, I mean, if we use the half dose antag like how we do during the
One can use, but then again, antag is not something which we want to have at the time of prior to embryo transfers unless there is a special situation. So I don't recommend using half dose antag for IVF. Half dose antag can be used in IUI or ovulation induction natural intercourse cycles if in case you want to. It doesn't
but how does it
cause
change?
such a big damage.
No, but how does it change? Whether it is IVF or IUI, it is just the follicle that you.
It agreed. But in HRT cycles, there is no follicle also. So if in case you're giving a half dose antag, you're probably trying to block some receptors on the endometrium, which is what we don't want.
Mm, mm. I do that, and I have got decent results. I mean, maybe it wouldn't have changed even if I had not done it. That's a different thing. Yeah.
Yeah.
What about ovulation induction in low AMH? I think this is a long question. Um,
But the short answer is you can either use low dose HCG protocol or you can use an extended letrozole protocol. Okay. And we have discussed it in our master classes. So people who are interested, go through those master classes.
so here is a case of secondary infertility, 30-year-old, done 3 cycles of ovulation induction, all the time weekly positive urine pregnancy test. Her AMH is normal, semen analysis normal. So what would you recommend?
Nothing. I mean, biochemical pregnancy is probably due to HCG 10,000 trigger, which has been provided.
Mm,
So, biochemical pregnancy is nothing to do with her getting pregnant as such, any which ways. So I don't think one should change the approach at all in this case.
mm. So if day two progesterone is 4.5, how do you proceed for
Rule
stimulation?
out any corpus luteal cyst, first thing. Rule out any ovarian cyst. Basically, what I mean to say is just rule out any cyst which is present. And if there is any cyst which is present, then you can give one cycle or maybe two cycles of oral contraceptive pills, because a high progesterone is going to affect the LH in the next cycle. Okay. Unless you are planning to do a dual stimulation and it's an IVF cycle, then it probably wouldn't matter. Then you can give a pre-treatment antagonist and go ahead with it.
Yeah. So 2 to 3 small intramural fibroids in the uterus. Any special precautions to be taken while doing an embryo transfer?
Can I understand the definition of small?
Maybe less than 3 centimeters.
How far from the endometrium?
Intramural. I mean, nothing like. So you tell what is the cutoff or what is your cutoff from the endometrial
No,
cap?
anybody who is distorting the endometrial cavity has to go out. It's a
Yeah.
very simple rule. Forget the size. Okay.
Mm. So if it is not distorting, see, you see that like proper distance of say around 1 centimeter, and there is absolutely no distortion. Okay, but the fibroid is between 3 to 4 centimeters. Would you
It's okay.
still
One
like
can
to?
go ahead and transfer. No, one can
Yeah.
go ahead and do the embryo transfer.
So have you done this use of the atosiban in these cases, which can get stimulated while you do the embryo transfer because of your negotiation, and it may start any activity on the uterus? Have you used
Not
atosiban?
tried, but I think there are people who are telling that
Yeah.
atosiban may work in these type of cases, but I have not tried, and I have not found a reduction in my success rates because of not giving atosiban so far.
No, maybe it will improve, I mean, you never know unless you try, right?
There are no atosiban receptors on. I mean, there is no oxytocin receptors which are present on the uterus at that stage. When there is no HCG, there is no oxytocin.
Mm.
So I really don't know how it would work, but then, I mean, some people are trying it and they are saying it is good. Maybe some data comes in, maybe we'll start using. No problem.
So after trigger, if the follicle doesn't rupture, what to do? I think, yeah, you can take this.
No, so you divide this into two categories, and we've answered this multiple times, right? Either the quality of your trigger has to improve, or if it is a luteinized, unruptured follicle, then we've had a beautiful masterclass on that as to how to evaluate an LUFS based on the conditions inside the pelvis, and then you can go through that masterclass, which will help you get a guideline on it. Okay.
Mm. So hyperplastic endometrium in FET. So how do you deal with it? As in, what is the cutoff for you to say that it is hyperplastic?
3 consecutive cycles, young lady, endometrial thickness in the menstrual phase, just, day 5 to day 7 has to be more than 12 millimeters. Okay. In that situation, you should take a biopsy.
No, 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 not in
Then,
the gynae case. In the FET stimulation, you have started an HRT. So when do
Mhm.
you think, like, on the day of progesterone, when do you say that this is like hyperplastic
Maybe
endometrium?
if it is more than 12 millimeters on that day, the
So,
standard is to keep it between 8 to 11.
okay, so you don't go beyond 11. Do you cancel and then do you try to reduce the dose of estrogen, or do you transfer earlier before it reaches 12? What do you do?
Yeah, so I think you can cut off, don't reduce the dose of estrogen, just
Not
call
in
her.
that cycle.
No, no, in the subsequent cycle, don't
Hmm.
reduce the dose of estrogen, just call her 2, 3 days before.
Hmm, 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 hmm,
No need to reduce the dose.
hmm. Okay, FET or in FET cycle, if there is a cyst or a follicle of 15 millimeter, say on
Do
the day
E2.
of the progesterone.
Yeah, do E2. And usually, if there is a cyst of 15 millimeter, you should have seen it on the second day and not
Hmm,
on the 10th day.
hmm.
So, but if you are still seeing it on the 10th day, do E2. Okay.
Yeah, repeat FET failure. Do you do the endometrial fluid aspiration and do a culture sensitivity or do a gene expert for TB?
None of this we will be doing unless we do a hysteroscopy.
Hmm.
So
So
the
for
rule is
culture,
hysteroscopy.
okay. So some embryology part questions. For culture dish, is it must to put one step media for gassing? I mean, I don't know what it means.
No, no, no,
Or
no,
we
no.
can directly put one step media of room temperature and overlay with oil.
Uh, all media needs to be equilibrated, even if it is single step or sequential. Okay. So if in case your culture plate has been prepared and kept straight in the incubator, then you keep it 6 hours before you put the embryo inside that. Okay. Unless it is a pre-equilibrated media.
Does 100 ml oil bottle can be used for 2 to 3 cycles?
2 to 3 cycles means
As in like batch IVFs, batch cycles, probably.
how will 100 ml suffice for 3 cycles?
Or
Usually it will finish. Usually it will finish in the first batch of 10-12 patients. Yeah.
100 ml.
Yeah, 3-4 ml will go, no? You'll do overlay. You will do overlay for the ICSI plates, you know. So oil will
Um,
go.
Also, heaps can be used for 2 to 3 cycle. I mean, what are these questions? I don't know. Some embryologist must only be asking. Hmm.
Use 1 liter HEPIS if you want, because the HEPIS is going to be used during oocyte aspiration as well as a buffer media. It is going to be used in sperm preparation as a buffer media. It is going to be used for washing the gametes. If you are doing IVF, then it is going to be used in next day to use the flush outs. So I mean, why use 100 ml? Yeah, bigger bottles are available.
So, follicle is 16 millimeter on day 2. So, do you recommend giving ocipil in that cycle?
No, no, do estrogen. See if the estrogen is less than 50, you can start stimulation.
Any effect of regular short cycle with short follicular phase on 11th day ovulation? Any effect on the oocyte quality, they mean?
No,
And what's the cutoff value for the DNA fragmentation index beyond which you say that the prognosis is not great?
repeat value of DNA fragmentation more than 30. You will need to do IVF ICSI only. ICSI only, honestly.
Okay. Role of karyotype and PGTA in young couple with one IVF failure and no prior history?
No role.
When not to do surgery in endometrioma? Oh, this you should answer.
When the size of endometriosis is less than 3 centimeters, okay,
Mm.
and when there is absence of a nodule. See, most important thing which people love to miss out is presence of a nodule. If there is a bilateral endometriotic cyst, chances that you will have a deep endometriotic nodule is close to 90%. If you have a unilateral endometriotic cyst, chances that you will have a nodule somewhere is approximately 60%. In a situation where there is an absence of nodule, you need not operate. Because when the nodule is absent, high possibility that the ovary will be a mobile ovary. And the mobile ovary with an endometrioma is not an issue at all.
You mean to say the additions are more important? See, we
No, no, no,
see
no. No, 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 no. What I mean to say is usually what will happen is if there is a bilateral endometrioma, there will be a nodule which is present somewhere. The thing is, we have missed out on that nodule, and somehow we are trying to convince using some 25-year-old HRA guideline that surgery is not indicated. Understanding? That is not correct. If you don't want to operate, no problem. But it is important to understand that you give the patient in writing because somebody is going to tell the patient the truth. Understanding? So I think it is important this way. If the size of the endometrioma is less and there is absence of a nodule, you can go ahead with a primary stimulation.
Okay, so how to decide whether to go for blast culture and number of embryos needed due to risk of arrest?
No, no, no. Just be positive and go ahead. Do blastocyst for everyone, not to have such a thought.
Yeah. Role of embryo glue?
Fevicol is much better than embryo glue. but embryo glue is bakwas.
You should just say yes or no. Should HCG be given after FET along with progesterone until how many weeks?
No, should not be given. Even
Oh,
it should not be given. I mean, it can be given when you have used a GnRH agonist trigger in a fresh cycle, but here we are talking of FETs, so definitely we don't give.
in case of recurrent implantation failure, is thymosin injection useful?
I think it is. We have used approximately 200 so far, and
Wow.
uh, and I think I think it may benefit. Okay, but maybe we'll wait for 2-3 more months before we include it as a part of our protocol.
Mhm. So triple layer more than 7 millimeter endometrium, but poor flow in HRT, what to do?
Nothing to do. Add ecospirin, and if the eco texture is good, probably you can add a low molecular weight heparin just in case you want to increase something, and go ahead with transfer. Because
Can,
this flow which you see is just on 2D, so you don't really know the 3D architecture.
can we stimulate patient for ovulation induction and IUI when patient is on DHEA for low AMH? Do you do that? Do you use
Yeah,
at
yeah,
all?
DHEA has no role any choice, so you can do stimulation with DHEA whenever you want.
And one doctor has asked, please request Dr. Jay sir for demonstration of his excellent skills and tips and tricks in embryology as in other videos. There is no basic things explained as which number dish is used for what. I think it is for embryology.
Okay, we'll have a session on that. Which
Yeah.
dish for what? Good session. We'll have.
Okay.
But if you want to use just one dish, okay, and if you don't want to invest and confuse the daylight out of your embryologist, then the best dish to invest is in a centerville dish. Okay, it's a
Mm,
beautiful dish.
mm, okay. So, para one living one, abortion one, 44 years, wants to conceive after second marriage, AMH less than zero point 0.1, male 34 years, asthenospermia, DFI more than 40%, undergone IVF with donor egg, had missed abortion, diffuse adenomyosis.
My God, I think even God will not help in such cases. But then still, if God decides to help, then one can probably try to give letrozole plus registrone for this diffuse adenomyosis if the size is less than 10 centimeters, and give it for maybe 90-100 days or so. And if the size of the diffuse adenomyosis goes down, then probably, and if they have good embryos despite such a high DNA fragmentation, then go ahead with a transfer.
So, FSH versus HMG in IUI cycle
HMG.
and agonist trigger when and why.
Oh, we have a masterclass on that. When, why, how, everything we have explained.
Yeah. The trigger class is very good. Actually,
Yeah.
very, very good class it is. Um, yeah, here I'm done. So, see, the commonest questions that I have got so far is like, that main the follicle or there is a cyst on day two, how do we stimulate? So there are two people have asked the same question. So previously not stimulated, as in like no stimulation for 6 months, and now on day two the patient has come. There are multiple follicles around 2 to 3 centimeters, and E2 is 1100. Okay, so
And
two
it is
similar.
1100 on the second day.
Yeah.
Okay. It's very, very difficult. Okay. Because, I mean, it's difficult to absorb this. At an E2 of 1100, the endometrium will not shed. Okay.
Mm. Mm.
So, a lady getting into menses, and this is a made up history, honestly. It's
No,
not
no,
possible.
no. They sent the report also. I will share it in the group if you want to.
She must have just had a hyperestrogenic bleeding. There must have been no secretory changes inside because estrogen of 1000 is huge for anybody to get bleeding, madam.
Mm.
In fact,
Okay.
in very thin endometrium, people give estrogen shots, right, to build up the endometrium and then give progesterone priming to stop the bleeding.
Yeah, tell this. I mean, there was this question a day before, I think somebody had messaged me on Sunday. So every time she starts estrogen for the FET stimulation,
Mm,
so currently on day 9 or day 10, the patient will start having spotting. Okay.
mm, mm.
So endometrium is around 7 to 8 mm, and then
Yeah,
this gynecologist will give tranexamic acid, and the bleeding will stop after 2 days.
yeah.
So, how do you tackle this? I mean, there is a triple line, or we just ignore it and move on, wait for another 3, 4 days for the spotting to settle down, and just get on with what we
No, no,
usually.
no. No, 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 no. This spotting is mostly coming from the cervix. Okay. Very, very, very high probability that there is something in the endocervical canal or in the exocervix, like a cervicitis or an ectropion or something, and you need to do a speculum examination to look at the cervix. 100%. Okay. Because if you are saying it's a triple line endometrium, then the possibility that it will bleed is not so common, madam.
Mhm. Yeah. And we'll take from the chat box. What if in FET cycle ET is 8 but poor vascularity and high uterine artery PI?
Add ecosprin, but probably you can abandon this cycle and start ecosprin and then stimulate for the next cycle. Just in case something improves, then it improves. Otherwise, Bhagwan Bharose.
Mm. So, as per new ART law, how many months of fellowship in ART is mandatory and from which places? Any guidelines for which these centers are recognized?
I know, no idea.
Yeah, you you have never done a fellowship in your life. How will you know?
Yeah.
In PCOS patient with letrozole induction in natural conception cycle, how many number of dominant follicle we should avoid HCG to avoid OHSS?
No, 2 to 3 follicles probably in natural cycle is a decent one. Can give HCG 10,000.
Can letrozole be started on fifth day of LMP if the patient comes on that day?
Provided there is no recruitment of the dominant follicle. Once the dominant follicle is recruited, you will have monofollicular development only.
Okay. What advice for youngsters you want to give if they want to start fertility and IVF practice?
Focus on your practice.
No, they should watch that masterclass where you mentioned how to establish fertility.
Maybe. Yeah, maybe. But they should learn to focus on their practice rather than focusing on Instagram.
You can't say that. How does half dose antagonist help?
Yeah, there is a master class on it. Please go through it.
Sir, in FET cycles, when progesterone keeps coming high on day 6, 7, tried natural cycle and stimulated cycle. But why do a progesterone level on day 6 or day 7?
I have no idea.
Okay. Thin endometrium, despite okay hysteroscopy, what are your hacks, your prescription?
We have already discussed it beautifully in the masterclass on thin endometrium. Really, one must go through it.
Yeah. Cause and management of early follicular development, say like 20
Low
mm.
AMH.
Yeah, I agree. Low AMH and 20 on day 10 is quite okay only. I don't think
20,
we.
yeah, it's okay, but otherwise, low AMH is the cause.
Yeah. Sometimes we have two follicles on day 7, sizes 17 millimeter, 12 millimeter. I tried half dose antag because ET was 4.5 mm. Now day 9 follicles are 21 and 14. ET is 5.1 when to trigger.
Now,
No, but why to trigger? I mean, can we just not leave it? I mean, why
no,
would
a half dose has been given already, no? So maybe one half dose has increased that endometrium by a millimeter or so.
Oh, but this half dose is such a beautiful thing, you know. You just see that one day makes so much of a difference with regard to the endometrial, the catch-up growth it does.
Yeah, yeah, absolutely.
So primary infertility, 35 years with low image, less than zero point 0.1. What protocol for you, or do you follow, or should we advise direct IVF?
You can try low dose HCG if you want. It's a good protocol.
Mhm. So sometimes hemorrhagic cysts develop after ovulation induction. How to manage with more than 3.5 centimeter cyst and patient needs ovulation induction as the husband is planning to travel.
That's tough because with a 3.5 centimeter cyst, you need a rest cycle.
Hmm.
Otherwise, the size of the cyst will increase. So the best option is let the husband travel, freeze his sperms, and do IUI.
So, have you noticed any difference in the success when you freeze the semen
No,
sample and do the IUI?
no, no,
So,
it's
does
the
it
same.
depend on the technique of the freezing by any chance,
Yes,
or
100%. No, by every chance. It depends on the technique of freezing. Do not wash the sample before you freeze it.
you just freeze it like that and then
Just
thaw it
freeze it
and then
and then
wash?
thaw it and wash it. Yeah.
Oh. How to deal with isoechoic endometrium in proliferative cycle during ovulation induction, not getting hypoechoic triple line?
Yeah, there is some endometrial cause. Do a hysteroscopy.
If LH and FSH value is almost same, do we consider it as PCO? Yeah. Hmm.
Up to you.
How can you say that? I mean, you have a PCO guideline where the FSH LH ratio, if
No,
it is altered.
it's okay. I mean, why do FSH and LH in PCOS? Forget it.
So, what is your criteria to diagnose PCOS? You don't do FSH LH.
No, clinical history. The irregular cycles, chronic anovulation, hirsutism. That is much more important, no? Rather
No,
than looking at FSH and LH.
the same spectrum you see in a lot of patients with low AMH. I mean, if you really notice it, except for the part of hirsutism and acanthosis, except for that, I think many a times you see very similar or common symptoms between this low AMH, especially like these
But madam,
multi.
it's better to rather than doing FSH and LH, just put a probe. And if you're so worried of low AMH, you will have low antral follicle count, and that will virtually establish the diagnosis.
Yes, I agree. Role of triptorelin in fresh transfer.
No role.
History of ectopic. Every patient should be counseled for diagnostic
Repeat
history.
ectopic on the other side.
Yeah. Can you repeat treatment for diffuse endometriosis? It's been repeated so many times. So, yeah, role of
No,
melatonin.
there is no treatment for diffuse endometriosis. There is treatment for diffuse adenomyosis. Okay. There is, if you have diffuse endometriosis, that means you are talking of diffuse endometriosis on the uterus, which is focal adenomyosis of outer myometrium, and peritoneal endometriosis that requires a surgery. There is no medical management.
Sudden decrease in the ET on day 10 of the estrogen.
Oh, that is usually going to happen if you are using a modified natural cycle protocol and if it
Hmm.
is a poor quality egg.
In FET cycles, in normal or low AMH cycle with very low estrogen, patient gets thick endometrium and have to cancel cycles. What to do?
Do a hysteroscopy.
Yeah. Hmm. If for withdrawal bleeding, progesterone is given, some patient bleed after 3 to 5 days, but few bleed after 10 to 15 days. Why do you think so?
Their vascularity of the endometrium is not so good. That is why all these differences happen. Otherwise, it's 5 to 7 days is standard, after the last tablet.
And also, I think it is about the estrogenization of that endometrium.
Hmm. How severe it is, correct?
So, if AFC is less, is Clomid useful during stimulation? I know
No,
you don't use Clomid, but you should be like, unbiased when you answer this.
I am unbiased. The answer is no.
It definitely has a role. Okay, if you have used letrozole for more than like say 2 to 3 cycles, and if it is not working, and if the patient is not willing to take injections like gonadotrophins and all, then definitely one cycle of Clomid can be tried.
Try, but it is not going to be that effective because if letrozole is not working, then HMG is the standard of care. What people are talking, they are not willing to take injections. It's like you want to have a child, but you don't want to send them to school. ऐसा कभी सुना है क्या?
What? How can you compare that to that? I mean, people come with all sorts of like, their ideologies. They don't want to, like, first they will come and say, we want to only conceive naturally. Then next
No,
level
that's
is like,
okay, madam. Everybody wants to become Mukesh Ambani. Many people will talk many things. That does not really mean that you listen to them. One has to put their foot down and talk. If they can't absorb truth, get out.
It's okay.
Hmm.
We are not Dr. Jay Mehta. We are like, just practicing
Ah,
gynecologists.
please. See, the minute you charge them nicely, no, they will listen to what you say.
Let's
Okay.
not talk about the
Hmm.
charges.
Any which ways. Yeah, forget it.
Please tell something about IVF in renal transplant recipient patient, how to go about it.
Oh, that's a good question. Look at how well her serum creatinine has been um, without any form of suppression basically over the last 2 years. Look at her blood pressure. Look at the EGFR. After you look at these three things, then you start planning the dose. Always treat them with letrozole along with HMG and ensure that the estrogen levels don't go up because any which ways, they have a little thrombophilic state, all these guys, because of too much of immunosuppression which has been given. They will have had anemia, and many other problems due to all the things which they've had in the past. Okay. So in that situation, ensure that the estrogen doesn't go really high up and uh, do your stimulation as normal. Do pick up under local anesthesia. Okay. And usually they will respond well. But be careful in the pregnancy because in pregnancy it is where the main problems will start. The problems don't really happen in egg pickups. The problems happen once they are pregnant. The blood pressure will go up and nobody wants to compromise that kidney which has been transplanted. Also remember one thing, the transplanted kidney is in the pelvis. Okay, this transplanted kidney is not where it is. So a recipient has three kidneys, two, and then one which is transplanted. Nobody does nephrectomy for those kidneys. Okay, so they have three kidneys, and when you want to measure the Doppler, you are supposed to measure the Doppler of the pelvic kidney. Okay, that's an important thing to remember.
So some patients complain of continued spotting just after period stop. So can we start induction if ET is 4 and all looks normal?
And if there is no polyp, yeah, probably yes.
On day 9, if follicle 19 can we give trigger? Yeah. How to induce a
Yeah,
short patient with 20 days cycle? It's the same.
letrozole. Yeah,
So can you give HMG after 10 days of extended letrozole follicle size of 15
not
millimeter?
needed. No, no, not need. Maybe one or two shots because of this 15. You want to go to 18, but
Mm,
10 days of extended letrozole is enough.
mm. So any special precautions while inducing in patients with diabetes for IVF?
HbA1c less than 6.5?
Okay. Can we give in a ovulation induction? Can we give in a patient with past history of acute porphyria, intermittent porphyria?
Oh, you must get a medical clearance for all that, huh? Because
Mm,
it can affect liver enzymes and all these things.
mm. So if there is high value LH values on day 6 of IVF stimulation,
Hmm.
can a double antac be given?
No. Why?
No, they're just asking. Okay.
No.
And if the LH is high on day 6, should we reduce the dose of HMG?
No.
Okay. Yeah, I think we are good. Uh, Anything else you want to
Okay.
add?
No, no, this is enough.
Yeah, you drank 3 times water. Okay, thank you so much. Mm,
Okay. Thank
yeah,
you.
bye. Thanks. It was wonderful. I mean, I think we should do it after every 20 sessions so that we kind of clarify doubts of so many people. Yeah, but thank you. Thank you for your time. I know it is a long session today. Thanks.
Bye bye.